Good afternoon, doctors. On behalf of Hetero Healthcare, I, Dr. Prashant, welcome you to this webinar on Carbetocin in action. Doctors at Hetero Healthcare, we have got 25 years of excellence, 300 plus products in portfolio. We have 36 state-of-art manufacturing facilities and presence in 126 plus countries. We have 21,000 employees globally, and we are amongst the largest manufacturers of ARV, APIs, and FDFs in the world. We have Asia's largest API manufacturing facility at Visakhapatnam, Andhra Pradesh. Hetero Healthcare Doctors is 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching out to customers across India. We have a wide product range encompassing multiple specialties, pioneering in quality and innovation. We have distinction of bringing 4 biosimilar products to market within 5 years of initiation. Now, today's meeting, Carbetocin in action. We all know that Carbetocin is a drug which is used for prophylactic management at PPH. You all agree with me that PPH is a potentially disastrous condition, can lead to disaster. And this condition is best to be discussed, read, and what I'll say, discuss rather than seen in the practice. It's a dangerous condition. We don't expect anyone to it. Although there are many papers or many guidelines for use of carbetocin in PPH, we always would like to have our own doctors' insights into use of carbetocin in PPH. For that, today we have got Dr. Jyotsna Kamra with us. Welcome, madam, to this webinar.
Thank you, sir.
Dr. Jyotsna Kamra is MBBS from SMS Medical College, Jaipur, and MD from GMC Patiala. Madam is ex-HOD and Professor MAMC, Agroha Hisar, Fellowship in Laparoscopic Gynecology, Fellowship in Infertility, Fellowship in Gynec Oncology from Mumbai, Fellowship in Aesthetic Gynecology, Master Training Course in Respectful Abortion by WHO. Madam is past General Secretary of Hisar Obstetric and Gynecological Society, past Vice President of Hisar Obstetric and Gynecological Society. Madam has conducted various laparoscopic workshops in Hisar, lifetime membership of IIG, Haryana Endoscopic Society and FOXY, various national and international publications and presentation on state and national levels, COVID National Warrior Award 2021 and Hisar Cover Award in 2022. Her areas of expertise is obstetrics, laparoscopy, aesthetic gynec, coloscopy, infertility and oncology. Once again, welcome madam to this webinar for your inputs on PPH with carbetocin.
Thank you, sir. Thank you for this lovely introduction. So, I think today topic is very important for every gynecologist and obstetrician who are doing OBS practice. We know that postpartum hemorrhage, it's like a nightmare for an obstetrician. It can happen to any patient anytime, and we all should be well versed how to deal such disastrous condition. So let's start with the presentation. We know that PPH, if we talk about conventional definition of PPH, it is loss of blood around 500 ml during vaginal delivery or more than or equal to 1000 ml during cesarean section. But this is a conventional definition. If we talk about practical point of view, if there is any loss of blood from the vagina or from the genital tract during delivery, uh, which causes deterioration in the health of the patient, which causes hemodynamic instability in the patient, that is known as PPH. PPH is very common and it can occur in any women. In fact, around 40% of female undergoing delivery without any risk factor, PPH can occur in such patients. And it is one of the leading cause of maternal mortality, particularly in low socioeconomic countries and developing countries like India, and it is one of the main cause of maternal death globally. So if we talk about the incidence of PPH is around 2 to 4% in vaginal delivery, and it is around 6% in cesarean section. The MMR is the maternal mortality rate. It is around 240 per lakh live births compared to 16 in developed countries. And if we talk about India, it is around 540 per lakh live births. So compare the data globally as well as India, the rate is very high. Again, because of lack of knowledge, because of lack of infrastructure and the methods to prevent PPH. So it is one of the leading cause of maternal mortality. Around 35% of all maternal death are because of PPH. Etiology of PPH, we can divide the etiology of PPH into 4 T's. The most common is tone, uterine atonicity. The second is trauma. Third is tissue, and lastly is because of the thrombin. The atonicity is inability of the uterus to contract. So the main, after delivery, the uterus contracts and retracts to prevent the loss of blood. If that function will not perform by the uterus, there are various reasons for that. It could be because of multigravida, multiple pregnancies, over distension uterus because of polyhydramnios, big size baby, large placenta, or prolonged labor. A patient is exhausted, patient has given is under anesthesia. In all such conditions, there could be chances of atonicity, and this could lead to PPH. Then comes the second cause, trauma. Trauma to the birth canal, rupture of the uterus, lacerations in the vagina, extension of the angle of the episiotomy, uterine inversion, extension of your cesarean incision scar laterally. All these can lead to PPH. So these two factors, tonicity and trauma, causes the main etiology of PPH. Then comes the tissue retention of the placenta, products of conception, clots, and few abnormal placental bits will be there. Lastly is thrombin coagulopathies that lead to PPH because of failure of clotting factors. Because clotting factors are not there in the body, they are coagulopathies are there because of PIH, eclampsia, IUDs, multiple patient having history of abruptio placenta, patient have placenta previa, or some other deficiency of coagulation factor that can lead to PPH in such patients. So comes how to identify the PPH. If the first most common clinical finding is obviously vaginal bleeding, then comes the hemodynamic instability in the patient. There will be tachycardia, there will be low blood pressure. If there is intra-abdominal collection of blood or intrauterine collection of blood, there will be increase in the abdominal girth, abdominal tenderness, and on palpation, there will be loss of tonicity of the uterus. So when you examine the patient according to the loss of the blood, if the amount of loss of blood is around only 10 to 15%, the blood pressure changes and tachycardia will not be there. But yes, if patient is anemic, such less amount of blood can also cause hemodynamic instabilities, and in such cases, even such amount of blood loss can be considered as PPH. So delivery status of patient is also very important. In mild, moderate, severe, the blood loss will be around 15 to 25% in mild, 25 to 35% in moderate, and 35 to 45% in severe. And as the blood loss increases, the blood pressure will fall, the tachycardia will be there, and there will be anuria, collapse, and even death in such patients. So diagnosing the PPH is very important. Each obstetrician should be well versed with the protocol of PPH, how to manage the PPH. They should have all the arrangements in their labor room with OT, with anesthetists on call. And initial evaluation is important. Check for the vitals of the patient and check how much blood has been lost, and try to identify the cause immediately, and side by side continue the resuscitation. Like send all the investigation, start 2 IV line, start fluids, ask for the extra help, and call for blood products, so that resuscitation should be start immediately. Then initial evaluation, find out the cause, whether it's traumatic, whether it's atonicity, or it is because of tissue or coagulopathies, and manage the patient accordingly. So the most common cause, as I already told, is because of the loss of tonicity of the uterus. In such cases, start by manual compression and massaging, then call for help, start your fluid, send the samples for the investigation, rule out the traumatic cause, and start your uterotonic agents. Uterotonic agents, we know that we have oxytocin, carbetocin, prostaglandins, methergins, carboprost, and if still bleeding is there, then we need to intervene in a form of some surgical method, or we can go for the uterine balloon tamponade, or uh, in, in rare cases, sometimes we need to go for the hysterectomy. Then comes the trauma. Find out the cause of the trauma. Where is the trauma? Where is the laceration is there? If there is any angle hematoma, treat it immediately. In all such cases, I already told, resuscitation should be continued. That is, fluids, blood products, investigations, and all the products that are needed for the replacement should be in your hand, and continue with it. Investigation to be sent. And then lastly, there is retained tissue or coagulopathies. If coagulopathies is there, replace it with the products. And if it is retained tissue, you need to take the patient in OT for the removal, manual removal of the placenta. Check for any retained products of conception, and you need some procedure like gentle curettage for the removal of such products. So now comes to the carbetocin. We know it's a new heat stable formulation. So what is the difference between carbetocin and oxytocin? Carbetocin is synthetic analog of oxytocin. It is stable at room temperature, has a longer shelf life. It has shelf life of 24 months, and at 30 degrees centigrade and 75% humidity. No need of cold chain storage, and it is available in vial and can be given IM or IV. Now comes to oxytocins or ergot alkaloids. They need cold chain. They need to be stored between 2 degree to 8 degrees centigrade. So heat stability is not there. That's why their efficacy is not that much that is expected from them. So in poor countries where cold chain transport or storage cannot be maintained or is not available, oxytocin is not a good choice. And I think carbetocin, which is a heat stable product, can be used, and it's much better than oxytocin. Now we have different uterotonics with us, various oxytocins in our armamentarium, like oxytocin, carbetocin, ergometrin, symptometrin, mesoprost, and we need to give all these, one of these or multiple of these according to the condition of patient to in our delivery patient. Like prophylactically we can use to prevent PPH in the active management of third stage of labor. Therapeutic multiple uterotonics are required in case of management of PPH. I already told you it's a synthetic long-acting analog of oxytocin. It prevents PPH due to uterine atonicity. One vial of carbetocin is 100 microgram in 1 ml of solution. It can be given IM or IV. It has more half-life, and it has better outcome and result than oxytocin. So these are some trials conducted which showed that this is WHO champion trial, which has shown that carbetocin is not inferior to oxytocin. It is in fact better and comparable to oxytocin in prevention of PPH and in loss of blood during delivery. The frequency of blood loss of at least 500 ml or use of additional uterotonic agents with carbetocin was proven to be non-inferior than oxytocin. So in conclusion, carbetocin is not inferior to oxytocin, and it is better in prevention of blood loss. This is Cochrane review, which showed that women who undergo a cesarean section, it has better results, and it causes less blood loss, and need for other uterotonics is also less in vaginal delivery as well as in cesarean delivery. WHO as well as other societies like SOGC, New Zealand Society, FIGO, Germany, France, they now all recommend Carbetocin as a first line of drug for the active management as well as for the prophylaxis of PPH. My experience with Carbetocin, yes, I'm using it since a long time. And when I was in medical college 2 years back, I started this product over there. And I made it available in the pharmacy, and we were using it. I was totally satisfied with it. Now I'm in a private practice since 2 years. So since 2 years, I think right now I have touched wood by God grace. No single patient has undergone PPH, and routinely, yes, I am using Carbetocin.
Madam, God bless. You should never get a patient of PPH,
Yeah,
even if we
yeah,
market Carbetocin, if you
yeah,
know how
yeah.
it is. Just to ask, you generally prefer IV route or IM route?
Sir, I'm giving IV route.
IV route.
Yeah.
As a bolus or a diluted?
Bolus, sir.
Bolus. Why I'm asking is that means a pre-filled syringe of Carbetocin would always help you to, I mean, even a slight few seconds faster use will anytime help in these cases, I
Yes,
suppose.
yes, sir, yes, sir.
And secondly, what I wanted to ask is that you generally use it, I mean, as soon as the baby is delivered?
Uh, Sir, yes, after delivery of the
Yes,
baby, but
baby.
before
Placental
delivery.
removal.
Yeah, yeah.
You do. Okay. We'll go as we go to the questions. You have already shared this in the point. Okay. Would you use this in now? You're using it in every patient, all patients, you say, no?
Yeah, yes,
Whether
sir.
high risk or low risk,
Yes,
but
sir.
you would use
Yes,
it.
sir. Because PPH, I told you, sir, 40%
Yes.
patient may can't predict.
And
Any patient can undergo
madam,
PPH.
yes, the most unfortunate thing of our science and especially gynecology is expect the unexpected. You don't know
Yes,
when
sir,
the
sir, sir.
unexpected
Yes, sir.
is.
Yes, sir. Very unpredictable branch. You
Absolutely.
never know
No.
कि everything is going fine. Your patient is not
Sudden,
anemic and good, well built. Everything is okay, and suddenly there will be
yes.
blood loss, excessive blood loss, and you need to
Bapre.
rush in such cases, sir.
What is the patient profile? Now, whether I mean, you can get in any patient, but generally, what's the patient profile where doctors can anticipate a PPH?
Yes, sir. I think I have explained in my
Yes.
previous slides also. Those females like multigravida,
Multigravida.
yeah, elderly primey. If there is multiple pregnancy, twin pregnancy, triplet is there,
Past
or
history, maybe.
polyhydramnios is there, past history of PPH,
Correct.
and if a patient is like labor has been prolonged, or
Okay.
patient some anesthesia has been given to it, so all these conditions there are more chances of having
Yeah,
PPH.
anesthesia will reduce the tone,
Yeah,
and then yes.
and then comes the sir PIH patient,
Oh.
diabetic patient. They have macrosomic babies.
Correct.
And abruptio of patient is having placenta previa or
They will
abruptio
always.
placenta accreta, percreta. So previous cesarean section, they are at risk of having
Yes.
PPH.
So straight away, that's best to use Carbetocin straight.
Yes,
To
yes,
those
sir.
patients. When would you prefer Carbetocin over oxytocin? I mean, you have been preferring in all patients. Why take a risk? But in generally places, I suppose in high risk patients, one should straight away prefer
Yes, sir.
Carbetocin.
Better. If high risk, go for the Carbetocin.
Correct.
And it has advantage. Only single dose is required, not a multiple infusion or multiple injections, or use of other uterotonics is also reduced. So overall, if you compare the efficacy as well as the cost,
Correct.
so it is better than oxytocin and other uterotonics.
Correct. Can we use Carbetocin in case of retained placenta?
Definitely we can give it in umbilical vein also.
So that placenta separates.
Yeah, we can use it.
And Rh negative mothers?
Definitely, sir. So you have to give Carbetocin. You can give Carbetocin in Rh negative mothers, but you again the entity to be given, that is
that is yes, correct.
the Carbetocin can be the only, I think, contraindication for Carbetocin is epilepsy, severe eclampsia, or patient having cardiovascular problem or allergy to oxytocin or something.
Then we have to be careful.
Yeah.
But with the Rh negative mother in the interiors or in the periphery, even if she lady starts bleeding, that getting blood is also an issue there.
Yes, sir. Yes, sir.
Can a doctor use Carbetocin for prevention if oxytocin is used for induction or augmentation?
Definitely. I think there is
should not be any
yeah,
contraindication.
we can.
You have been using preferring IV routes, you said.
Yeah, but it has shorter time to start. It takes 2 minutes.
Immediate action. But any place for IM? Otherwise,
I am can be given, sir.
yes. Why would one wait rather than have a faster
Uh-huh.
action?
If I think if suppose everything is fine, your IV line is not there, your
Then
staff is
yes,
not well trained. In that cases, you can go for
yes.
the IM.
I
Otherwise,
But it's more of an exception than the rule.
yeah,
Exception, the rule is, and of course, as you said, a pre-filled syringe anytime will have an edge over the
yes,
norm.
sir. Hmm.
Because kitna bhi ho to removing that thing from the ampule and etc. It takes time.
Yes, yes, sir. Yes, sir.
If the patient is not responding adequately with carbetocin, which can happen, what additional
Yeah.
additional uterotonics would be used?
Additional utotonic, what I am using is carboprost, sir.
Carboprost.
Huh. Otherwise, mesoprost, oxytocin infusion, or this methergine, you can, if there is no contraindication to any one of these
Methergine would be
utotonics.
hypertension. Methergine would be
Otherwise,
hypertension.
sir, most of the in rare cases we need
Yeah,
utotonics.
correct.
Then, if I'm using carboprost in such
Correct.
cases.
Carboprost. Correct.
Yes.
And advantage of carbetocin over loxytocin? If
Yeah, I have
oxytocin, you have
already
said
told,
yes,
sir.
yes, yes, yes.
The,
And
the
with misoprostol, carboprost, do they have side effects which carbetocin do not have?
Mesoprost, carboprost, they have very patient. They generally suffer nausea, vomiting, pain, abdomen, diarrhea, and fever. These are very common
And of course,
complication
yes.
with mesoprost and carboprost that is not there with carbetocin. Oxytocin, the patient have more chances of hypotension, and antidiuretic effect is more
Yeah,
with oxytocin.
how common is this ADH effect with
No,
oxytocin?
no, sir, it's not very common
No,
because
no.
we are not using it
Absolutely, yeah,
for
yeah, yeah.
prolonged time or
Correct, correct.
in very high amount. We are not using. All these are theoretical. Oxytocin overall is safer drug than mesoprost and carboprost because
Correct.
they have. I have seen each patient they vomit. They have vomiting after carboprost. They have abdominal pain. They have diarrhea, fever. It's very common, but definitely
And again,
carboprost.
they are prostaglandins. We can't use them in asthmatics also.
Yeah,
That's another
yeah,
issue.
yeah,
Yeah.
yeah.
Should carbetocin be kept as a reserve drug? Obviously, no. The answer is
It
why
should be
should it?
first line, yes.
Yeah, just
Single
because
dose, safe, effective.
correct, correct, correct. And why should one wait keep it for a How would you compare adverse? We have already discussed these points.
Yes, sir.
But
Yes.
any hemodynamic effect of carbetocin you have seen, or hemodynamic adverse effect of carbetocin you have
No,
seen?
sir. No, sir. Single dose, no, sir.
Single dose, no. And
Hmm.
essentially single dose. I suppose the most important advantage of carbetocin is no heat, cold chain required,
Yeah,
single
yeah.
dose, no
So I
IV
told you
formulation
because
openness.
oxytocin need cold chain, the efficacy is most of the time is very less when we
And
are
if
giving the
even in
oxytocin.
places, even in big cities, there is a power outage. Interiors
Yes,
and
yes, sir.
periphery, we do not know.
Yes,
We do
sir.
not know how people will be maintaining it.
Yes, sir.
And last is your one liner on carbetocin, your own recommendation or your own
Obviously,
experience.
it is effective, it is safe, it is tolerable, and carbetocin is better. Go with it. First line of management. If patient is not responding, then go with other utotonics.
Thank you so much, madam. I mean, sharing your experience with doctors, I'm sure they must have benefited rather than reading articles and this. Practical experience is practical experience
Yes,
finally.
sir. Yes, sir.
Thank you
Thank you,
once
sir.
again. Thank you once again.
Thank
And,
you, sir. Thank you.
and I thank all the participating doctors who took time from their schedule and attended this. Thank you, marketing team Hitro for conceptualizing. Thank you, sales team for coordination. Last but not the least, thank you, IT team for support. Thanks once again, madam, and sorry for last time's
Yes, sir. Yes, sir. It was some problem from my side, so I should
no
be.
issues, no issues, no issues. But thank
Okay,
you so
sir.
much for a lovely meeting. Thanks once again. Thank you.
Thank you, sir.
Wish you a very good evening.
Thank you, sir.
We can log out.
Okay, okay. Thank you.